Hi, good morning. Today we will be discussing sequential segmental analysis of the heart with a specific reference to some common congenital heart defects. So, as far as congenital cardiology is concerned, whatever imaging modality you use, whether it is fetal echo, postnatal echo, CT scan, MRI scan, cardiac angiography, whenever you describe a congenital heart, you need to do it in a sequential segmental manner. And that will ensure that you don't miss any abnormalities as you're making a diagnosis. So, although cardiac defects may seem very complicated, actually, they are very simple if you do the analysis in a sequential segmental way so that you describe the abnormality at each level. So once you get into the practice of doing that, then when you give the final diagnosis, you just have to put everything together at the end and you have your complete diagnosis. Okay, so whenever you analyze a fetal heart, don't try and jump to the diagnosis, or always do a stepwise analysis so that eventually you can put your abnormal findings together and then you'll have a complete diagnosis. Okay, so in the next half an hour or so, we will try and look at each segment of the heart and some common abnormalities that happen at each of the levels so that you get a broad understanding. Okay, this is just an introductory lecture. And the key learning point I want you to take away from this talk is that, there are no kind of individual or specific diagnostic groups as such. There can be a combination of abnormalities at various levels as far as the fetal heart is concerned. So the number of possible abnormalities is actually quite many. So the important thing for us is to pick up the abnormal findings at each level, put them all together, and try and come up with a composite diagnosis. Obviously, certain abnormalities occur together, and that you will learn, as your clinical experience grows, that certain things commonly happen together. But the important thing, especially as a beginner or a learner, is to do things in a systematic way and make sure that every segment of the heart is well imaged and well visualized so that you can pick up any abnormalities that are present at that segment. So moving on, so we know that the heart lies in the thorax and 1/3 lies to the right of the thorax normally and 2/3 to the left. If you look at the right border of the heart, it is comprised of the SVC and the right atrium. If you look at the inferior border, that is usually occupied by the right ventricle, and the left border, you have the apex, a part of the left ventricle, the pulmonary artery. So this is how you would normally find the heart within the chest in a postnatal situation. Okay. Now, when we look at the segments of the heart, so how is the heart actually divided into segments? Normally, you have the atriums or the atria, whichever terminology you want to use. You have the right atrium and the left atrium. Then the next segment is the ventricles. Between the atria and the ventricles, you have the atrioventricular connection. The third segment is the great arteries or the arterial trunks. So between the ventricles and the great arteries, you have the ventriculo-arterial connection. So you have the atriums, the ventricles, the great arteries, and in between these various segments, you have the atrioventricular connection and you have the ventriculo-arterial connection. So generally, we tend to describe each of the segments and each of the connections to understand the abnormal or normal anatomy of the heart. So the first step in the analysis of a congenital heart is situs determination. Okay, so although all of us look the same on the outside, we are not the same on the inside. That is, the right side of us and the left side of us, if you look at us on the outside, we are more or less symmetrical and same. But on the inside, our organs are completely different. So in situs solutus or usual situs arrangement, generally you have on the right side, you have the right atrium characterized by the right atrial appendage. You have the right lung, which is trilobar. You have the right bronchus, which is broader and more of a direct continuation with the trachea. Then on the right side, you have the liver. So these are all certain characteristics on the right side of us. On the left side, we have the left atrium with the left atrial appendage, which is quite different from the right atrial appendage. We have the left lung, which has only 2 lobes. We have the left bronchus, which is more slender and at more of an angle to the trachea. On the left side, we often have the stomach and we have the spleen. So you can see that the right and the left side of us on the inside are quite different. As far as cardiac situs is concerned, situs is usually determined using the atrial appendage as a landmark. So the right atrium has the right atrial appendage, which is usually very broad. It is completely filled with pectinate muscles. So the junction, these muscles actually extend from the appendage up to the junction with the right atrium of the appendage. Whereas on the left side, the left appendage is usually hook-like or finger-like, much smaller, and the pectinate muscles usually are more towards the tip of the appendage, not up to the connection with the left atrium. So the right atrial appendage and the left atrial appendage actually morphologically look very different. And these atrial appendages are the ones which determine which atrium it is. However, as you all know, atrial appendage is quite difficult to image. So then we use certain surrogate information to determine the actual atrial situs in the heart. Now, we will discuss that as we move further. Now, you have normal situs or situs solutus, where you have the right atrium on the right side and the left atrium on the left side. You can have mirror image or situs inversus, where you have the right atrium on the left and the left atrium on the right. And then you have these conditions known as heterotaxy or isomerism. And what isomerism essentially means that instead of having a right side and a left side, there is either 2 right sides or 2 left sides. So you have 2 right atriums and you have 2 left atriums. Okay, and similarly, the same isomerism is reflected often throughout the body. Sometimes you can have combinations of situs presentations where one organ shows a different kind of situs presentation and the other organ can show so various things can coexist. But as far as the heart is concerned, you have situs solutus, situs inversus, right atrial isomerism, and left atrial isomerism. These are the 4 common usual situs presentations that we are concerned about. So this we already discussed, right? In usual arrangement of situs solutus, you have a trilobed right lung, a bilobed left lung. You have the right atrium on the right, left atrium on the left. You have the liver on the right, the stomach and spleen on the left. So this is what one would find in a normal person. If you have mirror imagery, everything just gets flipped over. So now you have the left lung on the right side, the right lung on the left side, the left atrium on the right side, the right atrium on the left side, and then the spleen and stomach go on to the right side and the liver flips over to the left side. So it's like an image that is seen in a mirror. Okay, so this is situs inversus. Now, if you have right atrial isomerism, you have 2 right atria. You also have 2 right lungs often. Okay, so both the lungs are trilobed, both the bronchi look like right bronchi. The liver is often in the midline, and there can be malrotation of the intestines. Because the spleen is a left-sided organ, the spleen can be absent in these patients, and this is termed as asplenia. Now, when you look at left atrial isomerism, you have 2 left lungs, 2 left bronchi, Two left atria, again often a midline liver malrotation once again being possible. And the spleen, because there are two left side, you have multiple spleens, often small spleens. So this is known as polysplenia. Now, from a functional point of view, whether it is asplenia or polysplenia, these are often not functionally normal spleens. So they will have to be considered as functionally subnormal spleens. What we tend to do when we evaluate them is we look for Howell-Jolly bodies on the blood smear. And often these patients will be on antibiotic prophylaxis against encapsulated organisms. They also require vaccination against encapsulated organisms. So these are special precautions for these patients. This is a CT image of right atrial isomerism versus left. You can see that both these bronchi are short and bilaterally. They look similar. These are right bronchi and these are left bronchi. Okay. Now the bronchus, the right-sided bronchus, is considered to be an eparterial bronchus. That is, the right bronchus runs above the pulmonary artery. The left bronchus, on the other hand, is known to be a hyparterial bronchus. That is, it runs below the pulmonary artery. So these are other differentiating characteristics. Okay. Now we talked about the appendage morphology. This is the right atrial appendage, which is broad. Okay. And like I told you, inside when you cut it open, it will have pectinate muscles from the tip extending up to the line where it joins the atrium. Left atrial appendage, you can see, is very different. It is finger-like or hook-like. And here the pectinate muscles will usually be restricted more towards the tip of the appendage. So this is on echo. This is postnatal echo, where you can see the appendages clearly quite different. Okay, this is in the same patient. These appendages are actually much better seen on transesophageal echocardiography. Even transthoracic postnatal echocardiography doesn't delineate the appendages very clearly. Now, when we look at the heart in left atrial isomerism means that there are two left sides, right? So then you expect the right-sided structures will all be absent or abnormal. So IVC is a right-sided structure. So what happens? The IVC, when it tries to connect to the right atrium, there is no right atrium, there's a left atrium. So the IVC becomes interrupted. It becomes interrupted and continues upwards as the azygos and joins the SPC. So this is one abnormality you find in left atrial isomerism. Left atrial isomerism is characterized by interrupted IVC. Again, the sinoatrial node is found in the right atrium. Because there is no right atrium, there is no sinoatrial node. Then what happens? Other focuses in the atria might take up the job of the sinoatrial node. So you can get low atrial rhythm. So you can have some abnormal ECG findings. Now you have two left atria. So the pulmonary veins are coming back. What do? They are confused. Which atrium should I go to? So most often you find the right-sided veins going to the right-sided atrium, left-sided veins going to the left-sided atrium. So you can have bilateral pulmonary venous drainage. Left atrial isomerism is often associated with atrioventricular septal defect. Okay, so generally left atrial isomerism is associated with less complex cardiac abnormalities than right atrial isomerism. Right atrial isomerism has more severe, significant cardiac abnormalities. Usually, when you have right atrial isomerism, you have total anomalous pulmonary venous connection because both are right atria, the veins just go somewhere else. And also, you have pulmonary atresia as a combination. So this combination of right atrial isomerism, pulmonary atresia, TAPVC is a very bad combination, generally has a poor outlook in the long term. So that is for us to remember. So right atrial isomerism, we have already discussed a little bit, but again, here you have two right atria. So you can have two SA nodes. So on the ECG, you can have two different P waves. Then you have total anomalous pulmonary venous connection, which is quite common. Because the coronary sinus is a left atrial structure, coronary sinus will be absent in right atrial isomerism. And again, like I said, there can be associated pulmonary atresia. And of course, asplenia, because spleen is a left-sided structure. So these are some of the typical features you will find in right atrial isomerism in a patient with, when you look for congenital abnormalities. So this is as far as situs is concerned. It's just a broad overview for you to understand what situs means. So once you have determined the situs, generally we go on to looking at the systemic venous return and the pulmonary venous return. Systemic venous return, we already discussed that in patients with left atrial isomerism, you can have interrupted IVC, and the IVC continues as the azygos vein. So this is an embryonic vein, usually regresses, once the baby is born, but it can persist. If the IVC is interrupted, then the IVC may drain using the azygos into the SVC. So this is one possibility. Then you can also have persistence of left-sided SVC. Usually the left-sided SVC actually disappears as the fetus develops, right? But you can have persistent left SVC. This is something that you see very commonly. This results in a dilated coronary sinus, which is often a differential diagnosis on fetal echo for a primum ASD. I'm sure this is an exam question for you. So a persistent left SVC can drain into the coronary sinus, resulting in a dilated coronary sinus. There is an association, as you know, with LSVC, left SVC, with arch abnormalities, which is why we always monitor the arch in these patients. But anyway, that is by the by. Just a persistent LSVC may be an innocuous finding. It is something that can be found in a percentage of the population. In isolation, it is not something that we are worried about. Okay, so these are all kind of variants or aberrations that we find. Now, if we look further, okay, this is the persistent LSVC that we talked about. Sometimes they have a bridging vein. Sometimes they are completely independent with no bridging vein or only a tiny bridging vein. The persistent LSVC anyway drains via the coronary sinus into the right atrium. So it goes to the correct place. This is an image of a persistent left SVC into a hugely dilated coronary sinus going to the right atrium. Like I said, in isolation, this finding does not have any clinical significance. Here, on the other hand, the SVC is draining into the roof of the left atrium. This is a problem because here the SVC is actually draining into the left side of the heart, not into the right side of the heart. So it is draining into the left side of the heart, and that can result in desaturation of the systemic blood, and this needs to be addressed. So the SVC will have to be channeled in such a way that it drains into the right atrium. This can sometimes happen in the setting of isomeric hearts. Then we move on to pulmonary venous return. Okay, so pulmonary venous return, we know that normally the pulmonary venous return goes back into the left atrium, right? So you have the veins from both sides draining into the posterior atrium, which is the left atrium. Now you can have anomalous pulmonary. So as far as the pulmonary venous drainage or connections are concerned, there are a huge number of possibilities as to the abnormalities. So when all the veins are anomalous, that is, they are not draining into the correct place, we call it total anomalous pulmonary venous connection. Now, the most common type of total anomalous pulmonary venous connection is supracardiac TAPVC, right? So if you look at the right side at panel, the site of drainage, the most common site of drainage would be supracardiac TAPVC. When we are talking about total anomalous pulmonary venous connection. Then you have cardiac TAPVC. So supracardiac TAPVC drains into usually the innominate vein. Rarely it can drain directly into the SVC also, but usually it drains into the innominate vein. This is the usual pattern. Now, the next common is cardiac, and the most usual drainage point will be the coronary sinus. So you will see a dilated coronary sinus, but no left SVC. Then you have to suspect that there is, anomalous pulmonary venous drainage into the coronary sinus. Then thirdly, less common is the infracardiac TAPVC. This is the most dangerous type because it is often obstructed and the baby can be quite sick at birth. So this has to be recognized carefully. Okay, and there the veins actually descend below the diaphragm, enter the IVC through the liver, and then come back to the right atrium. So these are the three common sites of drainage in total anomalous pulmonary venous connection. In addition to total anomalous pulmonary venous connection, you can also have partial anomalous pulmonary venous connection. So here on the top frame, you see only one vein from the left side is going up. So from the left lung, the usual site of drainage will be the innominate. From the right lung, usually it will drain into the SVC, sometimes into the right atrium. So these are the common sites. So sometimes only one vein can drain. Sometimes an entire lung can drain. That's called hemi-anomalous pulmonary venous connection. And like we have already discussed, if all of them drain anomalously, it's called total anomalous pulmonary venous connection. Now, we talked about the common sites of drainage, right? Supracardiac, cardiac, infracardiac. Sometimes some veins can drain into one part, some other veins can drain into another part. So that is called mixed TAPVC. So under TAPVC, you can have supracardiac, cardiac, infracardiac, or mixed if they are going to multiple sites of drainage. Okay. So this is an anatomical specimen of supracardiac TAPVC. You have the vertical vein or ascending vein, innominate SVC. So usually in these patients, you will see exaggerated or increased venous flow in the SVC and the innominate. Now here, this is another anatomical specimen where the veins are draining into the coronary sinus. So here they have opened out the coronary sinus, all the veins can be seen draining into them. So like I said, when you see a dilated coronary sinus and there is no LSVC, and you have to make sure that the pulmonary veins are not, are draining normally, because they could be draining into the coronary sinus. Infracardiac TAPVC, usually the veins will enter like this, kind of it's called an inverted fern tree pattern. I remember from my training days reading it in some textbook. So basically you see how it's like an inverted fern tree, and it goes down, it descends below the diaphragm. That's through the descending vein, and then because it enters the liver, there is obstruction at the level of the liver parenchyma, the liver sinusoids, and then it comes back into the right atrium. Okay, so here again is a reconstructed 3D reconstruction from a CT. CT is an excellent modality for looking at veins. You see, this is from looking at the back of the heart, right? Upper and lower veins, left-sided veins also, all of them are coming and forming a confluence. Then if you follow my arrow, they are going up the vertical vein, they are entering the BCV, innominate vein or brachiocephalic vein, whatever you want to call it, going into the SVC. So you're looking at it from the back of the heart. So this is showing you supracardiac TAPVC. Here in the next panel, you have mixed TAPVC. So you have the right-sided veins and the left lower pulmonary vein entering the coronary sinus, and then the left upper pulmonary vein is going via the vertical vein into the innominate. So, look at the amount of variability in the venous drainage. So, obviously, all of this may not be picked up on fetal scanning. The exact site of drainage depends on the quality of images that you're able to obtain, the body habitus of the patient, the lie of the fetus, so many of these things. Okay, but as long as you suspect anomalous pulmonary venous connection and you're able to guide the patient accordingly, that is very good. That is good enough. Generally, anomalous pulmonary venous connection generally have a good outcome. We are able to repair them. The one determining factor that determines the outcome in these patients is the size of the individual pulmonary veins postnatally. A small proportion of them can have underdeveloped pulmonary veins inside the lungs. If that is the case, then their outcome may not be so good. But thankfully, this is only a small proportion. And this is something that you cannot make out in fetal life. So generally, our counseling in fetal life is upbeat and positive, because we do have solutions for these patients. After surgery, they can do exceptionally well and lead near normal lives. Okay. So now we have done systemic pulmonary venous connections. We move on to the atrial septum itself. Okay, the atrial septum, obviously, you know the embryology of the atrial septum. There are various components that fuse together to form the atrial septum as we know it. Okay, a disturbance in any one of these processes can give rise to an atrial septal defect. So there are the most common type of atrial septal defect is the ostium secundum atrial septal defect, which happens around this oval fossa region. Okay, so here you have in this illustration the oval fossa defect or the ostium secundum defect. Then you have the ostium primum defect, which is in the lower portion of the atrial septum. This is commonly a part of atrioventricular septal defect. You can see it as part of a complete AVSD or in isolation as a partial AVSD. Often this is associated with a common AV valve. So the AV valve will also be abnormal when you have a primum ASD. Then you have a superior sinus venosus defect and more rarely an inferior sinus venosus defect or a coronary sinus defect. So inferior sinus venosus defect, coronary sinus defects, these are all very rare. Whereas ostium secundum, ostium primum, and then followed by sinus venosus defect, these are relatively commoner. We see them in clinical practice. So sinus venosus defect, the superior sinus venosus defect, the top part of the atrial septum is deficient. And this is usually associated with an anomalous drainage of the right pulmonary vein. So when the surgeon fixes this, he has to make sure that the pulmonary vein is rerouted back into the left atrium. So you see here, that was just a diagrammatic representation. This is a CT scan where you can see the right upper pulmonary vein is anomalously inserting into the SVC instead of coming into the LA. So he has to make sure that he channels that right upper pulmonary vein down to the left atrium. So that can sometimes be tricky in very, very small babies. That is why in sinus venosus ASD, usually we don't rush to do the surgery in very early life. We want the structures to grow. Only then, without obstruction, the surgeon can actually, channel the right upper pulmonary vein into the LA. Okay. This is the rarer type of defect, the coronary sinus ASD. And here what happens is there are defects or holes in the coronary sinus actually runs behind the left atrium, right? So one of the surfaces of the coronary sinus is directly communicating with the left atrium, but normally it is fully intact. But if you have defects in that surface, then you can have left atrial blood entering the coronary sinus and then entering the atrium. So this will be like a left to right shunt, like an ASD. Okay, and then the coronary sinus mouth will be dilated. So next we move on to another abnormality in the atrium. Just notice that we are going one segment after the other, right? We did situs, we did systemic and pulmonary veins. Now we are looking at the atrial septum and the atria. Atrial septum, we have had a broad overview. Now this is the chambers themselves. This is a rare condition called cor triatriatum. That means that there is a partitioning of the atrium by a membrane. So what happens is that there is obstruction. So the top chamber will contain the pulmonary venous blood and there will be a membrane with a small orifice. So the pulmonary venous blood cannot freely flow into the left ventricle. So it produces something similar to a mitral stenosis, okay? But it is at the chamber level, it partitions the chamber and this condition is called cor triatriatum. Usually it happens on the left side, very, very rarely it can happen on the right side, okay? So now we have looked at the atria, we go on to the next level. What is the next level? Atrioventricular connection. Because you're going to the next segment, but before that you have to look at the connections. So the normal atrioventricular connection is called concordant, which means the right atrium is connected to the right ventricle, left atrium is connected to the left ventricle. You know the right atrium because it has a right atrial appendage. Left atrium, left atrial appendage. Now, right ventricle, what are the characteristics of the right ventricle? Usually the right ventricle is trabeculated. There is a moderator band. It always carries the tricuspid valve with it. Tricuspid valve is offset from the mitral valve. It is further displaced downwards towards the apex, and also it is septophilic. So there is a septal leaflet with attachments to the septum. On the other hand, left ventricle smooth walled, there is no moderator band. The mitral valve is at a higher level than the tricuspid valve, and there is no septal attachment. Okay, so you can identify the ventricles. So you have to make sure the right atrium connects with the right ventricle, left atrium connects with the left ventricle. That is concordant. Discordant, right atrium will connect to the left ventricle, left atrium will connect to the right ventricle. What is double inlet? Both the AV valves will be more committed to one ventricle. So one AV valve will be completely committed. The other AV valve, at least 50% will be committed. So 150% of the AV valves will be committed to a single ventricle. Okay, so that is double inlet ventricle. Most often it is double inlet left ventricle. Then you can have absent AV connections. Things like tricuspid atresia, no tricuspid valve, only mitral valve. Or mitral atresia, no mitral valve, only tricuspid. So that is the absent AV connection. We have common AV connection. You have the common AV valve, as you see in atrioventricular septal defect. So these are all the types of AV connections you can have. Okay. So now that we have discussed it theoretically, so this is the atrium, ventricle, atrioventricular junction connections. This is normal. So right atrium connected to right ventricle, left atrium connected to left ventricle. Mitral valve slightly higher than the tricuspid valve. Tricuspid valve is attached to the septum. Okay. So how do you differentiate AV valves? Mitral valve has no attachment to the septum. Tricuspid valve has attachment to the septum. And of course, there is the offsetting of the AV valves. So AV concordance, remember, each segment has to be analyzed separately. So when you have situs solitus, you have right atrium on the right side, left atrium on the left side, and you have concordant AV connections. RA is connected to the RV. LA is connected to the LV. You can have the same concordance, but in a situs inversus situation. Then you have left atrium on the right. It is concordant. So left ventricle will also be on the right. Right atrium on the left, which is concordant. So right atrium, right ventricle, both will be on the left. So that is why it is important to analyze each segment separately, so that it doesn't get confusing for you, right? So here you have situs solitus with AV concordance, situs inversus with AV concordance, okay? Now, with isomerism, things get a little bit more complicated and we won't go into it today. But this panel basically reflects that you can have any situs, usual situs, that is solitus, mirror image, that is inversus, right atrial isomerism or left atrial isomerism. You can have any AV connection, okay? And any form of ventricular dominance. So each of these are independent and each of them can exist with any of these possibilities. So multiple possibilities, exist, okay? So here you have an illustration of an absent right AV connection. Here you have a double inlet type of connection. Here you have an absent left AV connection. So you have an absent right AV connection, absent left AV connection. Okay, and even the ventricles, you can have a dominant right ventricle, you can have a dominant left ventricle, and then you can have ventricles where you can't determine the morphology. Okay, so we talked about double inlet, right? So here you see a typical double inlet ventricle. One valve is completely committed to the ventricle, and the other valve is predominantly committed. Okay, so this is what we mean by double inlet ventricle. AV valve atresia, that is absent AV connection we talked about. So here you have a diagrammatic representation, absent connection. Here you have the morphological specimen. Right atrium, no right AV valve. So whatever blood is in the right atrium has to go to the left, go to the LV, and then find its way out. Okay. So this is tricuspid atresia, a morphological specimen, right atrium, and then you see no tricuspid valve and a very hypoplastic right ventricle. And these patients can have associated pulmonary atresia as well. Then the opposite side, AV valve atresia, mitral atresia. So this is the tricuspid valve, mitral valve is atretic, and the left ventricle is smaller and hypoplastic. compared to the right ventricle. So this is part of a spectrum of hypoplastic left heart syndrome. Okay. Then you have common AV valve. So this is the usual AV valve where you have tricuspid and mitral valves. But in the common valve, it is just one curtain of valve tissue. And you don't actually call it tricuspid valve or mitral valve. You just call it the left AV valve and the right AV valve. Okay. So here is a morphological demonstration of the same. Okay. Where you have the common AV valve, and when you see it from the atrial surface, this is the kind of appearance you get. You have thickened leaflets, and it's a curtain of leaflets across the AV junction. So types of AVSD, you can have a complete AVSD where you have a ventricular septal defect and an atrial septal defect that is seen in the figure B. You can have just a partial AVSD, that is ostium primum defect alone, that is in figure A. You have only inlet VSD. So the atrial component is not there, only VSD is there, that is figure C. These are the various options. Sometimes the ventricular septal component is very small and it can be called a transitional defect. Okay. So we've talked about now the AV connections. We're looking at the AV valves themselves. Tricuspid valve normally has 3 leaflets: anterosuperior leaflet, septal leaflet, neural leaflet. The mitral valve has only 2 leaflets. That is it has the neural leaflet and the anterior leaflet. Okay. So the anterior leaflet is the one closer to the aorta. Neural leaflet is the one closer to the, neural means wall, the one closer to the left ventricular wall. Okay. So tricuspid valve anterosuperior, septal, and posterior or neural, you can call it either. You can call it an ASL, this is this leaflet, and anterior and superior, septal, which is attached to the septum, and posterior or neural leaflet. Tricuspid valve is septophilic, attachment to the septum. It always goes with the right ventricle, and it is more apically displaced than the mitral annulus. Okay. So this is the mitral valve attachment. This is the interventricular septum. This is the tricuspid valve attachment. So further lower down. One of the common abnormalities you see is Epstein's anomaly. Epstein's anomaly, this is what it looks like morphologically. Usually there is a significant displacement of the septal leaflet and the posterior leaflet. So the attachment itself is displaced significantly towards the apex. And the anterior leaflet may not be displaced, but it will be abnormal. Look here, this is the entire thing is anterior leaflet, and it has got a lot of kind of attachments or trabeculations. It's tethered to the right ventricle, very abnormal looking. So this actually should be the right ventricle, but it is effectively functioning as the right atrium. So it's called the atrialized right ventricle. Okay. So this is Epstein's anomaly. That's commonly seen with a tricuspid valve. Mitral valve, like I said, there is an anterior leaflet and a neural or the posterior leaflet. Mitral valve, again, usually the mitral leaflet and the aortic leaflet, there will be no muscle between them. This is what is known as aortomitral continuity. This is normal. So in double outlet right ventricle, we talk about discontinuity. That happens when there is muscle tissue between the aortic valve and the mitral valve. We'll discuss that later. Mitral valve, generally you have the leaflet, you have the chordae, you have the papillary muscles, and usually the mitral valve leaflets, you actually number them as P1, P2, P3, A1, A2, A3. So that's just the nomenclature, more useful postnatally. Okay. We won't go much further into it. This is the chordae, and these are the papillary muscles, just for you to understand the anatomy. So this is a surgical view of the AV valves. You have the tricuspid valve, the mitral valve. In between the two AV valves, you have the aorta that is wedged in between. So when you have a common AV valve, like an AVSD, this aorta becomes more anterior. It gets unwedged. Okay. So you can see that the pulmonary artery wraps around the aorta. So this is normal arrangement. This is what you see as a crossover. No? When you see on your fetal echo, this is the crossover. So the pulmonary artery is anterior and the pulmonary valve will be to the left. Okay, so this is the left of the heart. This is the left atrial appendage. Pulmonary valve will be to the left and anterior of the aorta. Aorta is more or less central, and behind the aorta, you have the mitral valve and the tricuspid valve. Okay. So this is how well you can nowadays image the valves. You get an almost surgical view. So just to compare the surgical view with the 3D echo view that you can get postnatally, almost ditto image. So it's very useful for the surgeon. Okay. So mitral valve, there are multiple abnormalities, prolapse I've just illustrated here, but actually there are many other congenital abnormalities as well of the mitral valve. This is beyond the scope of this talk. Okay. Now, once we have finished the valves, we go to the ventricles. Like we've already discussed the characteristics of the ventricles. This is the right ventricle. It comes with the tricuspid valve, which is attached to the septum, highly trabeculated, and it has a moderator valve. Left ventricle comes with the mitral valve, no attachment to the septum, finer trabeculations, no moderator valve. Okay, we know how to differentiate. Then you have between the ventricles, you have the interventricular septum, in which you can have ventricular septal defects. Depending on the position of the septal defects, they are variously called and classified. Again, you won't go very deeply into it. You can have defects which are in the inlet, which you see just below the AV valves, and then you lose that usual offsetting of the valves. You can have muscular defects. You can have defects that are just beneath the pulmonary valve as well, that are doubly committed defects. So multiple defects are possible. Okay. Muscular defects, this is just imaging diagram, morphological specimen, which shows you various types of muscular defects. Can be in the inlet, apex, outlet. Muscular defects are characterized by muscular margins throughout. Okay, that's what defines a muscular defect. Perimembranous defect basically is a defect which is between the tricuspid valve and the aortic valve, so that there is no muscle between them. They are continuous with each other. There is fibrous continuity. So these are all muscular defects, fully muscle bound. This is perimembranous defect. Okay. So tricuspid valve, aortic valve, there is no muscle in between. They become continuous. Then we talk about, you see aortic override, right? The tetralogy of Fallot. This is what it means. So it's the right ventricle, left ventricle. This is the interventricular septum, and you can see the aorta overriding the septum. Okay. So there are some defects which are just below the pulmonary valve, between the pulmonary valve and the aortic valve. That is called doubly committed. This is a type of VSD which is very uncommon in the West, but very common in Asia. So it constitutes nearly 30% of VSDs in the Asian populations. Okay. So this is a broad overview of VSDs. Then we go on to the chambers themselves. So in the ventricles, we've looked at the characteristics. We've looked at the interventricular septum. Now the chambers themselves, they can be asymmetrical. You know this. So this is a hypoplastic left ventricle with a very small aorta. Okay, it can have a stenotic mitral valve as well along with it. And often the inside, the endocardium, you see this glistening white kind of layer. This is called endocardial fibroelastosis. Okay. Then you can have hypoplastic right ventricle also. Again, you would have seen a lot of images of these kind of patients. So this is the other ventricle, which is hypoplastic. It can be associated with tricuspid atresia, tricuspid stenosis, pulmonary atresia, pulmonary stenosis. So all of this is possible. Effectively, when you have significant asymmetry of the AV valve and the ventricle, then this patient may not be suitable for a biventricular repair. So they will have to go for a single ventricle pathway. Okay. So now that we finished the ventricles, we go on to the ventriculo-arterial connections and the great arteries. So we already talked about the relationship of the pulmonary valve and the aortic valve in a normal heart, with the pulmonary valve being left and anterior to the aortic valve. So these valves are what are called semi-lunar valves. They have specific architecture, okay, different from the mitral and tricuspid valves. So both the aortic and pulmonary valves are fairly similar in their architecture. Okay, so there are various, we talk about ventricular-arterial connections, right? So There can be ventricular arterial concordance, where the left ventricle connects to the aorta, right ventricle connects to the pulmonary artery, or there can be ventricular arterial discordance. Ventricular arterial discordance, typically you see it in transposition of great arteries. So here, situs solitus, right atrium, right ventricle, but connecting to aorta. Left atrium, left ventricle connecting to the pulmonary artery. This is a life-threatening situation, but it can be easily dealt with after birth by arterial switch operation. Here, you have double discordance, that is, right atrium connecting to left ventricle. So, AV discordance and then left ventricle connecting to the pulmonary artery, VA discordance. Okay, then here, left atrium connecting to the right ventricle connecting to the aorta. So, AV and VA discordance. Here, if you see, the deoxygenated blood is actually going to the correct place, although it is going through the wrong ventricle. So, this is called double discordance. Otherwise, it can be called congenitally corrected transposition of great arteries. So, these patients will not have any cyanosis because their circulation is actually okay. Just structurally, they are going through the wrong ventricle. Okay. So, again, in inverses, you can have AV and VA discordance or only VA discordance. And, multiple combinations once again are possible. So that's what I want you to understand. So there can be only AV discordance, there can be only VA discordance, there can be AV-VA discordance, there can be situs solitus, there can be situs inversus, there can be a combination of these kind of findings. Some of the combinations are more common than others. Okay. So we talked about normal arterial arrangement. This is a patient with transposition of great arteries. So this is normal, the top panel. Aorta with the coronaries, anteriorly pulmonary valve. Here you see aorta anterior with coronaries, posteriorly pulmonary trunk. So normally on scanning, you will identify aorta and pulmonary artery by the branching. Pulmonary artery will branch early into two, aorta will go straight up and give the head and neck vessels. That's how we can identify. This is advanced imaging showing aorta coming from right ventricle, pulmonary artery coming from left ventricle. Okay. So we talked about various ventricular arterial connections. You can have discordant connections like we have described. You can also have double outlet scenarios where just like double inlet, we said that AV valves, one AV valve plus at least 50% of the other AV valve is committed to one ventricle. In double outlet, what happens is one outlet and at least 50% of the other outlet is committed to a ventricle. So you have double outlet ventricle. Mostly the most common is double outlet right ventricle. Okay. You can have a variety of double outlet right ventricles. Classification is based on the position of the VSD and also the relationship of the great arteries. Whether the VSD is below the aortic valve, below the pulmonary valve, and then whether the great arteries are normally related or transposed. Next, we go on to the great artery itself. So in the great artery itself, you can have truncus arteriosus where the two great arteries have not fully separated. So you have one common trunk, and from that common trunk, you have coronary arteries coming out, you have the aorta going, and you also have the pulmonary arteries. So that is one abnormality. Then you can have aortic arch abnormalities, where you can have hypoplastic arch or coarctation. You can have multiple arch anomalies like double aortic arch, abnormal branching patterns which give rise to vascular problems. You can have aortic arch, not only coarctation, you can have interruption. Now there is no arch, there is a gap. So the PDA will supply the lower limb and the ascending aorta will supply the head and neck vessels. So multiple arch abnormalities are possible. Okay. This is just an illustration of a coarctation. Basically, what we look for in coarctation is this posterior shelf. Many times on imaging, you will see an anterior shelf-like structure that is not usually significant. It is because of the PDA. If it's a large PDA, you can see an anterior shelf. What we are more concerned about is this posterior shelf. That is the important thing to look for. Okay. Here you see this looks like the arch, but actually this is the arch. Okay. This is the large PDA, and this is actually the transverse arch, very hypoplastic. Okay, so this requires extensive arch reconstruction. This is an example of arch interruption. There is no arch here. You just have the vessels heading upwards. So it's a very typical appearance of arch interruption. This is an example of a double aortic arch. I'm sure you've seen it on fetal echo. This is a CT 3D reconstruction showing it beautifully. Okay, so that gives you an overall overview of all the possible abnormalities and how to approach cardiac analysis in a sequential segmental fashion. Okay, so I hope this has been useful, and we will stop with this for today and meet again in our next session.